Okay. All right. Thank you guys for coming. This is a medical campus outreach event, Medical Campus Outreach Philadelphia. For those of you on Zoom, thank you for coming. And you are being recorded, just so you know. And you guys in the room, we are being recorded. So we will post this probably later on our website in a couple months. But thank you guys for coming. It's my privilege to introduce to you Dr. Dave Chen. We have known Dave for many, many years. You did Summer Medical Institute back in 2010?
I think it was 2010.
2010. And then everyone has met Woody, right? I think everybody's met Woody, the MCO administrator. Well, Dave married, not Woody, but Liz Mosebrook, who had Woody's job back in the day, the MCO administrator. So they met through Medical Campus Outreach Ministries and trips and stuff like that. So yeah,
ringing endorsement.
I know. So you owe us one of your children, just so you know.
Take it. We got 3, so take it.
Right. So let me do Dave's formal introduction. Dave is a pediatric and internal medicine hospitalist at Christiana Care Health System. He graduated with an engineering degree from Princeton and got his MD and MPH in health systems and policy from Rutgers Robert Wood Johnson Medical School in New Jersey. He completed a medical internal medicine and pediatrics residency at Christiana Care, and then the pediatrics portion was at DuPont/Nemours in Delaware. And he spent 2 years living in North Wilmington during his training. My understanding is North Wilmington is a bit of a
north side of Wilmington.
Yeah, and it's interesting neighborhood. Okay, good. He studies healthcare utilization and disparities on assault injured men and the impact of community violence exposures on health. At Christiana Care Health System, he's a physician scientist for the Institute for Research on Equity and Community Health, and the founder and medical director of Empowering Victims of Lived Violence, a hospital violence intervention program. Take it away, Dave.
Right. Glowing introduction. Thanks for having me here. I have like a million slides, so I'm going to be flying through them really fast. But before we do that, I think just speaking to the nature of gun or firearm violence, you have to be able to talk about it in personal terms because it gets very political very fast. And so the way this talk is structured is we're going to begin with a whole bunch of facts and the context for setting the stage of understanding the scope of firearms, firearm violence, ownership, all those sorts of things in the United States. And then that also informs how we understand its ripple effect in civil society today. And we're going to compare that with a couple sections of scripture as well. And so just to give a little more context for how I have come to really be involved with this. So I did SMI here when the first year I had come back to Philadelphia, by which I mean spent like a week or two living in literally Susan Post's house with the other people from SMI. And so just a couple blocks from here. And that was my first introduction, having grown up in the suburbs, to a lot of areas of urban life that I didn't know or didn't understand previously. Had only heard about, had only seen in the media, but didn't really know the day-to-day life impact of. And so after my SMI experience there, when I came to Wilmington in Delaware for a residency, I had committed, said, I really want to know more about the city. And so then I spent 2 to 3 years living during my residency on the north side of Wilmington. And, for context, Wilmington is a small city. It is majority Black. There's a lot of structural and historical inequity and racism that is there in the heart of the city. The neighborhood that I lived in on the north side also had very high rates of firearm violence. So in addition to hearing gunshots on a regular basis, there were even 2 instances where people were shot outside my house, and I was the first person there holding pressure on the wounds on the street outside. And that's part of what really began to open my eyes as to what I call that unique desolation that is firearm violence. There are many, many things that are unjust, that are devastating to the life of community. And these things range from housing to like hiring, to businesses, to environmental circumstances, all of these different things. But there's something that's particularly pernicious to firearm violence and how that ripples in a community. Not just the people who are directly injured, but their families, their friends, the neighborhood itself. And then it just kind of has this way of pushing and warding off all of the potential change that could happen by disrupting and by destabilizing neighborhoods in that way. And so through my experiences there, I was like, you know what, I want to understand this better and see if we can get at this root issue. Some of the other experiences that I've had, just clinically speaking as a hospitalist, recently I had a patient who was hospitalized for effectively a foot infection. And I asked them like, oh, so, what happened to you? What's your story? And the first thing the guy says is, well, when I was younger, I was shot in the head. And then it just kind of rippled out from there. And over again, there are these instances where things that I see in the hospital that I would not have initially or originally tied to firearm violence actually is rooted or disrupted or influenced heavily in part by that. And so what I hope to do here is to kind of paint this very broad scope and give us some language for being able to understand this and to talk about it and to really wrestle with it in clinical practice, in daily life, in community life, in areas that experience it. So that's kind of that context there. I do have some disclaimers. Fortunately, they're hard to read, but it's pretty much what I was saying before. I'm the medical director for our hospital violence intervention program, and what we do with that is for those that are hospitalized related to violent intentional injury, we essentially have what's effectively a community health worker and wraparound sort of care service program that follows them outside of the hospital after discharge for a period of time to try and reverse some of the structural as well as the health inequities that tend to affect people who are victims of violence. And our primary focus are those who are firearm injured. So a lot of what I'll be talking about is kind of informed by that experience as well. And so before we get started, it's important, I think, to just pause and individually in your mind and heart to consider your own beliefs and assumptions about firearm violence or gun violence. Right? And so here are some questions to help prompt that. What experiences have you had with firearms? Do you think positively or negatively about firearms? What causes gun violence? Are you afraid of a hostile response in even talking about guns? How do you feel about the police? Do you believe gun violence can be prevented? Are you afraid of threats of harm by others towards themselves or even towards you? So consider your own internal beliefs and thoughts and feelings around some of these questions. And when I ask myself these questions, my heart rate ticks up a little bit because I admit a lot of these things do evoke very strong emotions, particularly fear for me. I've been a hospitalist for a while now, years, and I was hospitalist throughout the COVID pandemic, right? And so you want to talk about being afraid. And what I realized was this very weird moment when talking with my fellow physicians and healthcare workers and nurses and our team was that was perhaps with COVID, the first time many of them in their life had ever felt like their life was in danger, like truly in danger. And they did not know, many of them did not know how to deal with that. It was such a foreign emotion to them. And it kind of clicked with me. I was like, this feeling I have in the COVID ward, just seeing people there, of being guarded in how I interact with each person here, even though they're people I know and I care about deeply, that's the same kind of feeling I had living on the north side, where you're always on guard, you're always on point. Even your closest relationships and family and friends, there's that element of uneasiness, of lack of safety that's there, that's pervasive, that you just live with. And that, I feel like, is the closest comparison that I can come up with in describing to other healthcare workers what it was like living in a neighborhood where you have frequent episodes of gun violence occurring. So, with that kind of context, I'm going to read for you this passage from Genesis, talking about Cain and Abel. So Adam made love to his wife Eve, and she became pregnant and gave birth to Cain. She said, "With the help of the Lord, I brought forth a man." Later, she gave birth to his brother Abel. Now Abel kept flocks, and Cain worked the soil. In the course of time, Cain brought forth some of the fruits of the soil as an offering to the Lord, and Abel also brought an offering, fat portions from some of the firstborn of his flock. The Lord looked with favor on Abel and his offering, but on Cain and his offering he did not look with favor. So Cain was very angry, and his face was downcast. Then the Lord said to Cain, "Why are you angry? Why is your face downcast? If you do what is right, will you not be accepted? But if you do not do what is right, sin is crouching at your door. It desires to have you, but you must rule over it." Now Cain said to his brother Abel, "Let's go out to the field." While they were in the field, Cain attacked his brother Abel and killed him. Then the Lord said to Cain, "Where is your brother Abel?" "I don't know," he replied. "Am I my brother's keeper?" The Lord said, "What have you done? Listen, your brother's blood cries out to me from the ground. Now you are under a curse and driven from the ground, which opened its mouth to receive your brother's blood from your hand. When you work the ground, it will no longer yield its crops for you. You will be a restless wanderer on the earth." Cain said to the Lord, "My punishment is more than I can bear. Today you are driving me from the land, and I will be hidden from your presence. I will be a restless wanderer on the earth, and whoever finds me will kill me." But the Lord said to him, "Not so. Anyone who kills Cain will suffer vengeance 7 times over." Then the Lord put a mark on Cain so that no one who found him would kill him. So Cain went out from the Lord's presence and lived in the land of Nod, east of Eden. So what are some of the features here that catch my eye? So some observations. Cain, he has this internal conflict with Abel characterized by anger. Right? It's mentioned several times. God warns Cain preemptively. The crime itself, homicide, murder, occurs in a physical space, a physical location. It describes it as the field, literally. Cain himself makes a rational decision to attack. God hears the grievance of the victim and is both witness as well as the judge. God inquires as he accuses. There's a conversation that takes place between God and the perpetrator here. Cain denies his guilt by denying brotherhood, right? By denying that community exists. Cain responds to the inquiry and eventually acknowledges offense. Cain's punishment is fundamentally related to his crime. He is excluded from brotherhood and community, and he is subject to the hostility of the environment. God hears Cain's response to punishment, and he shows mercy by shielding who? The perpetrator from further harm. And God himself uses threat of force as the way that he guarantees justice. Right? So these are observations that kind of pop out to me, and I want you to keep these in mind as we then go through a series of fast facts about firearm violence in the United States, all right? And what they mean. When I say fast, it's like 10, 15 seconds of the slide, okay? Because I won't have time to chat. So, fact number 1, not all violence is gun violence, so try and be specific about what you're talking and thinking about. Why do I say that? A lot of the conversation when we talk about violence, when we talk about firearm violence, gets derailed because people are picking things from one domain of violence and they're kind of making inferences that it immediately applies to a different domain of violence. And that's not usually the case. Different violences should be thought of differently. Right? They're usually very specific to a context, a population, a number of salient features. So be mindful, not all violence is gun violence, and be specific when you talk about it. Fact 2, there are different types of firearm injuries. So again, be specific when you're thinking and talking about them. This is a typology I kind of came up with. So when I think of firearm injuries, I think of unintentional, intrapersonal, and interpersonal, right? Unintentional, most commonly we think of pediatric, such as, say, the toddler that takes the gun out of the mother's purse, or dementia, the 80, 90-year-old that is, has a rifle or has a handgun, and in perhaps confusion, maybe uses that unintentionally. Intrapersonal, suicide, mental illness, right? Interpersonal with assault, and generally speaking, the interpersonal assault pretty well splits from intimate partner violence and then other types of assault, right? It's not perfect, right? These things are often interrelated, but the victim, the demographics, the mechanism, the lethality, those do split differently, right? And so I think it's helpful to think about it in these frames. Legal as another part of interpersonal firearm violence. And what I'll say specifically is suicide and homicide paired together is where mass shootings most commonly come. So again, there are different types of firearm injury, and be mindful of which ones you're talking and thinking about when you have those conversations. Fact number 3, there are more guns than people in the United States. I'm going to say that again. There are more guns than people in the United States of America, but gun ownership is concentrated. So actually the majority of households in the United States do not have a gun in them. You may have one household that has multiple guns, in part because people often own guns for sport, as a hobby. They collect them, they accessorize them, they enjoy using them for a variety of different things, as well as for what people describe as defensive measure, right? So yes, there are more guns than people, but that doesn't mean that everybody has a gun, right? This is really important because then when we talk about the demographics, we talk about ownership and possession. Not everyone who possesses a gun is the owner, and an owner may have multiple guns. This becomes very important later. Fact number 4, more gun deaths occur by suicide than homicide in the United States. I'll repeat that again. More gun deaths occur by suicide than by homicide in the United States. This data here is, I think, from 2020. And you can see the majority of are suicide. It used to be close to 60%. Shifted a bit in the past couple of years. Unintentional, undetermined legal intervention, each of them make less than 1% of gun deaths in the United States. Mass shootings make up much less than 1% of gun deaths in the United States. Again, framing the context, because what do you hear about in the media? You hear about mostly these mass shooting events. Yet, when we talk about the number of people killed by them, they're a very, very small fraction. Fact number 5, the reason why there are more deaths by suicide by guns than by homicide is because for a homicide, most people actually survive. When you think about it, it makes sense because if someone is intentionally trying to harm themselves by suicide with a gun, it's usually pretty lethal. They often don't even make it to the emergency departments. Oftentimes it's a bullet to the brain, and those are not as commonly survived. With an assault, it's usually ranged from a distance. Usually someone knows that an attacker is coming. Intimate partner homicide is usually much more lethal, right? Because it's usually within the house, usually closer quarters, and usually the victim is not armed or is not aware or has no ability to escape when it happens. When it's happening, say, out in the street or in the more of the community context, most people actually survive. So the thing is, well, there are actually a lot of then firearm injuries, even if they don't end in homicide. This slide here is a little bit older. This is going back to 2006 and 2014, but you can kind of see that here. For people who survived and made it to the emergency department, the mortality for suicide intent is up to 40% as compared to, say, unintentional assault. And a lot of this is because of advancements within the field of trauma over the past couple of decades as well. But again, the point, most firearm assault injuries are in fact survived. Fact number 6, guns are durable. What does that mean? Guns last a long time, years of time. So when someone purchases a firearm, that remains active, usable. It carries risk with it for the lifetime of that firearm until it is either destroyed or rendered non-functional. So the effects of ownership last as long as the gun does. This is a study from the New England Journal of Medicine in 2020, looking at handgun ownership in California. There were literally over 1 million people that were included in this cohort study. And what they found was the risk of suicide by firearm for firearm owners persisted for 10 years after the initial purchase of the firearm and ownership within the house, right? Again, they're durable. The effect of it lasts. So fact number 7, guns are transferable, directly relates to fact number 6. If they're durable and they last longer, there are more opportunities for it then to transfer hands. Guns also represent a fair amount of money, right? So a lot of the car break-ins and thefts are not simply looking for loose change. Oftentimes they're looking for a gun because then that carries fair amount of value on the market, right? They can be hundreds of dollars for a handgun, especially if it does not carry a history with it as used in prior crimes. And so after multiple transfers, the risk of it being able to then get into circulation within the black market for intentional use then goes up, right? So this study here, they interviewed a number of people in Cook County prison and asked them, where did you source the gun from? Where did it come from? And again, this is a smaller sample, or 100 people, but they said it was not from, say, robbing a gun store, right? That's actually very, very, very rare. Most guns that are then used in crime come through second, third, fourth, fifth, sixth hand purchases, transactions, what we call straw purchases. It's the question of where does that first purchase and transfer happen? And these are usually what we call straw purchases or thefts. They even found that a number of guns that were used in crimes going back, when they went to the original owner, the owner had never reported that the gun was actually stolen in the first place, right? And so it's this leakiness to the ownership of the firearm that eventually allows it to penetrate into the black market. And this is not well tracked, not really well understood, but it's a direct consequence of the fact that there are more guns than people in the United States. Guns are a durable firearm that generally retain their value over time, right? And can be transferred as a physical good. Fact number 8, a lot more guns were sold in 2020. When I say a lot, there were more guns sold in 2020 as a year than in any other year in history. Like any other year. Any other year. 2021 also had more guns sold than any other year except for 2020, right? 2022, down from 2021, but still more than pretty much any other year, okay? So what does that mean? Well, the other 2 facts we just talked about, what can you then begin to infer? We would not be surprised then to observe that more people have therefore been dying from firearm injury from 2020 and on since, right? It's just unsurprising. It's a matter of statistics, right? If you literally have more firearms than people in the United States, that is the natural consequence. So the thing is, though, that firearm injuries are worse for those who have been historically at risk for injury. So the people who are dying from firearm injury is disproportionate. So some populations have higher risk from the surge that we saw in 2020 and beyond than before. In 2020, not only were more people purchasing, not only were more guns sold, there were more new people buying guns, right? And so there are a lot more first-time gun owners as well. Then you also have, and now this is straying a bit from fact, and this is more hypothesis on my part, but you have a historic rise in gun sales. You also hit that with essentially economic instability and recession. You have these durable goods that have a lot of cash value to them. It does not surprise me then to see them then leaching into all of these other markets and then increasing the rates of firearm injury across the board. So this was from the MMWR looking at changes in firearm homicide and suicide rates from 2019 to 2020. And I'll read it here because the print is small. The overall firearm homicide rates increased 34%. The largest increases occurred among non-Hispanic Black or African-American males aged 10 to 44 years, and non-Hispanic American Indian or Alaska Native males aged 25 to 44 years. Rates of firearm homicide were lowest and increased least at the lowest poverty level, and were higher and showed larger increases at higher poverty levels. What does that mean? The highest mortality rates are among young men or adolescents, those that are Black, and those who face worse poverty, right? That's been the historic statistics in the United States for firearm injury, and these were only exacerbated with the surge in 2020 and beyond. Fact number 11, gun deaths are now the leading cause of death for children in the United States. I'm going to say it again. Gun deaths are now the leading cause of death for children in the United States. Children defined as under 20. Why is it important that I say that? Well, because it is mainly because it includes adolescents. This is from 2020 data, right? And you see here the rates of deaths per 100,000 people. Red line here is homicide, blue line here is suicide. And it's not, again, the toddlers so much as it is the adolescents, and as they go on through young adulthood as well. It is disproportionately in this kind of younger age bracket, and those that are affected, the bias here is within the Black population as compared to the others, just from a statistical perspective. The axis and the scales here are very different, right? And so this for the essentially early or the 20s gets up to over 100 deaths per 100,000 for young Black persons in the US, right? That's an incredibly high mortality rate for a group who did not have usually significant medical problems before this. So literally went from being fairly healthy to dead or severely injured, disabled, almost instantly. So those were fast facts, right? Now some questions and the obstacles to these. And so I don't have the answers here, but here are the things that are the crux of our conversation today about firearms and injury. So why are there then these disparities in geography, in race, and by poverty level of exposure, right? And then so the plot here is for homicide rates, and then down here is for suicide rates. And they're almost inverted by states geographically, right? A lot of that is why? Actually because of race. Now, there are some states here where they are high for both. It becomes really hard, though, when we're talking about things on the level of states to be able to estimate why that is. Here's an example. Let's look at Pennsylvania, right? So there's a little kind of color map here on the upper corner. And if you were just to look at the total population within Pennsylvania, and you were to look at firearm deaths, it's about the same as per 100,000 people in the population as to the national average, 13.7. Suicide rate for the total population of Pennsylvania is a little bit less than the national. Firearm homicides is 5% more than the national. Suicides less, again, homicide. But if you segment it down to the subpopulation, and you look at just homicides, and for Black non-Hispanic persons, big difference, right? For Pennsylvania as compared to the rest of the US. So, particulate firearm homicides, 46% higher than the rest of the United States on average, right? So again, the subset matters, right? There is this inequity that's there by race and geography within the United States, and also by income and a number of these other factors. How much do laws influence us and make a difference? That is a really, really hard thing to say, because what do laws govern is usually the state or the federal level. But we just made this observation that even within different states, even within a state, the patterns of injury differ between, say, the urban environment as compared to the rural environment or non-urban, by different demographies as well within the state. And so it becomes really, really, really hard to judge the impact of policy on this. There's better and more studies coming out. Generally speaking, the things that have good evidence saying that they decrease the rates of it have to do with what? Less access, right? It goes back to those statistical observations we saw earlier. Things that decrease the flow and the rate of circulation and sale and purchase of firearms then have a downstream effect of having less firearm injury that occurs later on in time. Again, it's a statistical thing. Next question. What is the impact of gun violence on communities? These are a number of studies I'm going to show you here. When there's a shooting that occurs and a homicide, the cognitive performance of children in schools within the next couple weeks immediately decreases, just by virtue of the fact that there was a shooting in the neighborhood. This is also reflected in attention and impulse control. Those are worse, again, in the immediate geographic area right after shooting, and that effect lessens literally the further out you go from where that shooting happened. So we know it's related to this geography. And this is Dr. Eugenia South here, a group author on this study. Mental health related pediatric emergency utilization. So this is a study in Philadelphia. But it said after shooting or shootings happen in an area, are there more kids that come to the ED with some mental health related issue? And they said yes, they noticed the observation. Those things worsen. What else? People who live in the community, so not just those that are directly injured or affected, describe having more hypervigilance, and in other studies is directly related to increased blood pressure. And we suspect that this then explains a lot of the disparities that we see downstream, such as related to chronically elevated blood pressure and stress, such as chronic kidney disease, diabetes, heart disease, stroke. We suspect that a lot of these are tied together in place with some influence directly related to firearm exposure. And then there's this increase in isolation and loneliness. And that's not just for the neighborhoods. These are for the adults that are living there. These are for the people who are directly victimized by the firearm injury themselves. Again, a lot of these being young men, that is not what many expect to happen after a gun injury, and yet that very much is the case. And I'm currently, disclaimer, working on a research study where we're doing direct interviews and focus groups, and this is what we're finding, is that there is that kind of isolating impact from that. What happens to the survivors? So this is question number 4. There is a higher rate of, kind of not surprisingly, diagnoses for things related to pain, psychiatric issues, substance use. Among family members within the same household, maybe slightly increased rate. Not quite as detectable, but for the victim themselves, for sure. For those that were directly victimized by firearm injury, tracking their outcomes 6 months later, 12 months later, they have, in comparison to someone that was also injured from, say, like a car accident, compared to that person injured in a car accident, those injured by firearms are more likely to have pain, more likely to have PTSD, and have worse physical and mental health related quality of life measures, right? Even given the same severity of injury as compared to someone that was injured in a motor vehicle accident. That's at 6 to 12 months. And then likely this is something that is then persistent over the life course. What is the impact of it on survivors? This study was looking at re-injury rates. So if someone was injured by a firearm and survived, within 10 years, at least 16% were re-injured again. For the highest risk subgroups, within 10 years, that's as high as 26% in this study. And this has been generally found in other studies in different cities and different neighborhoods. So what does that mean? If you had a heart attack that almost killed you, and you show up in the ED, and the cardiologist says, in the next 10 years, your risk of having another heart attack that could kill you is 26%, how would you feel about that, right? For those that are injured by firearm, that's the rate we're talking about. Again, a nearly 1/4 rate of injury within 10 years. Question number 5, what makes someone pick up a gun? So this was a small study, but a really interesting one, where they looked at people who had come to the ED with some kind of substance use associated among youth, and they tracked them over time to see how many then described new behavior of carrying a firearm when they didn't before. And they said, what are the factors that are related to someone picking up then a gun when they weren't picking up that gun before? So perception of aggression or actual aggression with partners, themselves having been a victim of violence or assault in some way, and having friends or other contacts that were involved with firearm violence themselves. And so this has given rise to some people saying that there may be, you can think about it almost as like a contagion, that violence is transmitted from person to person and is propagated through these social networks. The kind of anecdotal observations have been social media escalates conflict. Think about Cain and Abel. And that then perpetuates and travels very quickly then through those social networks. And when guns are involved, results in injury or death. So question 6, what's the difference between a root cause and a proximal factor as it relates to violence? This is a really important question, even though it's not talked about in this way very much. So I'm going to repeat it again. What is the difference between a root cause and a proximal factor? What do I mean by that? A lot of people have been talking nowadays about using the public health model to approach violence. Oftentimes, this is even talked about as a different or even a superior way to other models in addressing firearm violence, such as from the criminal justice system. People say, oh, public health is the solution because we note these associations in people who are involved with violent injury. And there are all of these what we call root causes. So some of these things are demographics, issues related to substance use, employment status, access by itself, cultural normalizations and acceptance of violence, exposure to violence, past abuse, cultural norms again, lack of support. You can go on and on through these things. So we say, well, we observe from a large population scale statistical perspective, we say, okay, for people who are involved with firearm violence, either as victim or as perpetrator, we observe these things more commonly. The problem is that these things affect huge swaths of the population in a city who will never be involved with firearm violence, right? As a perpetrator or as a direct victim. And so while, yes, root causes contribute and do need to be addressed to change the trajectory of firearm violence in the future, that is a very different thing from looking at the proximal cause. What happened right before the firearm incident happened that contributed directly to that? Why do I say that? Because a lot of the interventions talk about root causes, but then expect to see a turnaround and an impact in reducing firearm violence rates within 6 months to a year. Impossible. Impossible. It's just statistically not going to happen unless you have a persistent, impassioned, narrow, direct focus on those proximal factors. And you know what they are, you can name them, and you can intervene on them, and you can measure them over time. So This is, again, a really important question when we talk about interventions on the individual level, on the community level, on the policy level, on the city level, you name it. And yet, oftentimes it gets muddy, right? We kind of wiffle waffle, we kind of swap between the two, we mix them up without being more explicit and direct in describing what are those causal mechanisms. What's the pathway by which something turns from a root cause into a proximal factor? Thomas Abt, who wrote the book Bleeding Out, great reference. I'll show the reference later. He kind of says it like this: if someone shows up in the emergency department bleeding, what do? You stop the bleed, right? So you go and your interventions are targeted with high energy towards stopping that bleed if you want to save that person's life. That doesn't ignore all the other contexts, whether they have high blood pressure, right? Whether they have cardiovascular disease, whether they've got all these other sorts of things. But you won't have an opportunity to address those things if that person's dead because they hemorrhaged out, right? So address that bleed. Another parallel analogy: if someone shows up in the ED with chest pain, you're not going to say, well, tell me about your diet and exercise. Let's do some counseling and education right now about how you can manage that better. It's like, no, get the EKG. Do you need the cath lab, right? Save that person's life first. Intervene on hyperacute illness. But it's also important to be addressing these fundamental factors because that's what's going to change the landscape in the future. You can do both. We should do both. So don't get caught in false dichotomies, but recognize that there is a difference between these two things. Question 7, what actually reduces community violence? This is the literally multi-million billion-dollar question out there now. So this, again, coming from Thomas Abt's, this was from a paper. This is incorporated in his book, Bleeding Out. It's a nice little appendix there in the back. And what he did was he read through 1,000 studies, literally 1,000 studies, graded the evidence, kind of like a meta-analysis, if you will, and said, okay, what are the things from at least a law enforcement, not so much a healthcare, a law enforcement perspective, that actually changes community gun violence? So the ones in italics are, at the time of this writing, which was 2017, were not so clear that they worked. The ones that are not in italics definitely helped. And he broke it into this matrix, right? Vulnerable places, people, and behaviors, and then points of intervention. Primary prevention, secondary prevention, tertiary prevention, suppression, rehabilitation. These two are actually really criminal justice involved things. So either direct policing and intervention or the prison and incarceration system. So where have you heard these terms before? Primary prevention, secondary prevention, tertiary prevention. Same language used from public health modeling, but it just makes it more specific, right? We're proximal factors here, proximal interventions. So people, primary intervention, family-based therapy. People, secondary prevention, so exposed, right, at higher risk, cognitive behavioral therapy, family-based therapy. Tertiary prevention, this thing called focused deterrence or group violence intervention. How many people have heard of this? Group violence intervention or focused deterrence. This is the big new thing that you're going to, it's not that new, it's been around for maybe a decade or two, but you're going to hear about it. We'll come back to it later. It takes a little while to explain. But that is a policing-driven sort of approach. So by comparison, place and suppression. So things that have been in the literature at this time demonstrated to work are policing in a neighborhood and among hotspots trying to aggressively repair or to reverse what they call quote-unquote neighborhood dysfunction. Behaviors, and so again, you have this idea here that there are specific things which work well in specific places or with people or with behaviors and at different points of vulnerability. This is what at least the research evidence suggests. So, the title of this talk was Cain, Christ, and the Clinician. So, where does Christ fit in with this? And this seems like a bit of an aside, but let's take a step back. So I just threw a whole bunch of statistics, evidence, all this stuff at you. So let's take a moment to reflect, going back first to the narrative of Cain and Abel, right? What were some of those features that we just reviewed that showed up in that literally like historical, almost prehistorical narrative about Cain, right? Things took place in a physical location, in a geography that was vulnerable, right? Cain met Abel in the field where there were no other people to be able to intervene, right? No guardian or capable guardian in the language of criminal justice. Cain himself was the perpetrator. He murdered, he killed Abel, and he broke himself from community in doing so. That was part of the sentencing on him for that. He was isolated and cast out. Yet he felt like this was too much for him to bear. It would break him. And what he was afraid of was retaliation, right? He was himself afraid of becoming a victim of the very thing that he had perpetrated to other people. And the only thing that was able to secure him from that was an external force of justice, God himself, guaranteeing his safety, even though he was the one that violated that for somebody else. Why am I saying these things? Because that is not often the framing we hear from Christian contexts when we talk about violence and perpetration. We don't think about the perpetrator, the literal person who committed murder or attempted it, as someone that is necessarily worthy of protection. Yet, even before Christ was present in the flesh, God himself enters in a dialogue with the perpetrator himself and guarantees him protection by use of force. So, not necessarily making a direct correlation, but we see the criminal justice system trying to mimic that, right? Trying to provide some form of deterrence to crime occurring, homicide occurring across the board that even applies to the people who were perpetrators themselves. That is what interrupts cycles of violence, is the legitimacy of a force in being able to protect. And people who tend to pick up a gun often do so because they feel like they need to provide protection for themselves that cannot be guaranteed, that is not legitimately given in another context from another person, whether that's policing, whether that's somebody else. So one of the things you can look at is what they call the clearance rate, or the homicide clearance rate in a given city or jurisdiction. If someone is shot, how often is someone ever even arrested for that incident? And in our city, Wilmington in Delaware, for many years, that rate was less than, if you were murdered, it was like 20%, if that. That meant 80% of the time, no arrest was made in a murder. If you were shot and survived, that arrest rate went down to about 12% for long. Right? Which meant, again, almost 90% of the time, no arrest was made. There was no justice that happened, which meant that the person literally got away with murder or attempted murder. So then if you're the victim in that case, what are you going to want to do? You're going to want to protect yourself. But if you are in a economically bad situation from a variety of factors, right? Don't have a job, can't get a job, and you are not legally allowed to own or purchase a firearm because of perhaps activities that you may have been involved with and have a criminal record for, such as, as one example, sale of drug, then what can you do to protect yourself? Well, if you cannot rely on the police to provide a mechanism of doing that, the saying that we would hear on the streets, as associates would tell me, is better be caught by the police with the gun than caught in the streets without one, right? Which actually resonates with a lot of the kind of rhetoric around firearm ownership in the United States in general, right? It's that same idea. It's an expression of a lack of safety, that you feel like you must be able to defend yourself. And for some people, they also may feel the best form of defense is an offense. Or I was already assaulted and attacked once. That person was never arrested. Nothing came of that. So I better go get them before they get me and finish the job. So you can see how there is a logic and an intentionality that, honestly, in my opinion, it's kind of hard to argue against for people who do not have trust or reason to feel like they can trust or actual reason to trust those who have been charged with providing them that kind of protection. Right? We see parallels to this, we were talking about this earlier, in healthcare, right? The past couple of years with COVID. You want to talk about vaccination? You want to talk about trust? You want to talk about perceived legitimacy by these reputable or non-reputable sources? That went to pieces within the matter of like months, years, not even. And so we see how quickly trust can be lost, how difficult it is to regain it, how much of that has to happen on the interpersonal individual level, and how easily these things can slide into these cycles of retribution, of acts of defense. And so here, bring you the narrative of Christ and Pilate. And, running low on time, so I'm not going to go into detail, but you know the story. Jesus is falsely accused of breaking religious law, right? Not even Roman law, religious law at the time, and is being brought to be sentenced to death. And Pilate interviews him, right? So we see some parallels to the way Cain is interviewed by God. But what's different here is that it's reversed. Christ, instead of being the judge, here is now being brought forth as the perpetrator, as the guilty one, is falsely accused, is really inappropriately tried, and a wrong verdict comes out, and Christ is then executed literally by the state. Right? Violence is done to he who was not violent, he who was the victim, he who was without blame. And why do I bring that up? Again, so much of the crux of violence, firearm or any other type, is force applied to cause harm. How we respond to that and how people respond to that then manifests itself in these ways that are broken, that are understandable in their own internal logic, like what Cain was saying when he was saying, I will be cast out and then whoever finds me will kill me. And the justice of God in these ways often runs counterintuitive to what we feel like people should deserve or how they should be treated by the state or by people in the community. And so to bring forgiveness, to bring the view of the victim here forward is something that is also counterintuitive and something that is often very hard because it deals directly with unjust trauma that happens that may never be reversed in that person's lifetime, in that neighborhood or that community, either in the short term or the long term. It does not remove the responsibility that we have to recognize it, to call it by name, and to work to reverse those injustices and those inequities. But it gives us the sense that that is what Christ does. That is who he is. That is what he endured, what he continues to endure with our ongoing sinfulness towards one another and towards him. And what does it look like to then rebuild community in that way? What does it mean to live in community with people who have done incredible harm, unspeakable injury or death to others that live across the street from you? I would say that really only the framework of Christ can speak to that. Because there must be an element of forgiveness that takes place. That said, I'm not saying that is the prerequisite, and I'm not saying it erases the measures of justice that needs to take place in order to bring legitimacy to prevent future or further harm. That gets far beyond what I'm able to say or recommend. But that must be where our heart is to recognize that there is a desire to bring people back into community, to reverse that fallenness and that curse that happened with Cain, that isolation, that exclusion, that banishment that happens, right? When people land in incarceration facilities for decades of time, that's what's going on. They're being further isolated. They're being further driven from the community. That's broken. And so even if that is a mechanism of justice, there can still be restoration. There can still be reconciliation that happens in and through it. But we cannot necessarily look to the state to be able to provide it. What does it mean for the church and for Christian clinicians in particular to be able to begin to bring that out and to deliver that kind of healing in communities? We're almost at time. I have a bunch more slides about some like clinical pearls and tips, but I'm going to kind of summarize that as is. A lot of it comes back to principles, I would say, of trauma-informed care, if you're familiar with it. And part of it is just first listening to the perspectives, to the hurts that people have sustained over time, not just as those that were directly victimized or indirectly victimized, but even those who are quote unquote perpetrators, because so often they are the same person, right? They themselves had been a victim of one or many sort of injustices, not just on the direct personal level, but also on the structural and systemic level. When we talk about education, we talk about housing, we talk about employment, when we talk about all these other sorts of things, those are injustices that foster these things too. Like I said, from a root cause and other perspective. It doesn't absolve people from responsibility, but that's not our position as clinicians to judge. It is to work on the healing of the person in front of us. And a lot of that requires us to have and encounter very dark and very hard things. And what I would say is, having been doing this work for some time, the only way to persist, I feel, is through Christ and understanding and saying, I can't handle all of this, right? I can't be that judge, that jury, whatever. But Christ is, and Christ compels me to love and to care for the person in front of me, and that is what I will do. Seek their best as much as I can. So, like I said, a whole bunch of other stuff here, but I'm going to pause there and just ask for questions, comments.
Can you do the tips for all clinicians?
I can run through it.
Yeah.
Were there any questions? Just so I can start cranking them over in my head. Okay. So, clinical pearls, tips for all clinicians. Point number one, explain before you ask, right? So, this applies to everything from screening for the presence of firearms in the home, all the way to dealing and working with someone post-injury, or someone who is maybe even actively involved in conflict. Say, I like to talk about some things that can be a danger in the home. Give people warning signs about what you're going to be talking about as a sensitive or difficult topic, okay? Particularly if there's an injury that's been involved, or you suspect there might be an active conflict that's going on, make sure you warn them to not inadvertently make a disclosure that you would be obligated by the state to report, right? So say, before we talk, I want to let you know there are some things I'm obligated by law to report. It's important to make that disclosure up front, so that way they, who are not stupid, right, understand that signal that you're giving them, and will be more likely to tell you in at least safer terms for them and for you what they want to share and what may actually help them in the long run. The last thing you want to do is have them not recognize or not know that you're a mandated reporter as a healthcare worker. Say something that mandates you, or obligates you to report. You report them to who? The police, right? And then now you've broken, you fractured that trust. Oftentimes the police may not be able to do very much even with that disclosure. And so you've lost a lot of opportunity there to make a difference. when there really wasn't an outcome from that disclosure anyway. So that's why I always say, walk into these conversations early on by saying this, and work on your own phrasing in terms of how you can do it in a way that's not dismissive or blowing it off, but does send a clear signal that you have obligation that you must report to. You can say things like, I have some questions because I want to make sure you're safe. Emphasize that your priority, again, is taking care of them, the person in front of you, right? That you're not asking because you're morbidly curious about something. Don't ask if someone's incarcerated, like, well, what were you in for? That's an incredibly offensive question because it's not your business, right? It doesn't directly relate to what you're taking care of them for in front of you. Pearl number 2, ask for permission, right, before you dig deeper. Some of this is from just a basic trigger perspective, right? You don't want to unravel something that they're not really emotionally prepared to deal with yet and inadvertently worsen their feelings of trauma from it. So you can say, is whatever the incident is something that you want to talk about more? I understand if it's a hard thing. The reason why I ask is because there is this kind of concern that I have that I might be able to help you with, right? Again, offer things in terms of the phrasing of I'm here to help you. And I'm only asking these things because it helps me to be able to help you. And if they say no, you respect that boundary, right? And then you say, okay, and then move on to talk about something else. Other sort of phrasing, what have been your concerns or what are your fears about this? Are you afraid of being hurt? Are you afraid of being hurt again? Do you feel safe? Is another question. How are you feeling right now? So ask again for permission. Go to point number 3. Sometimes statements are actually better than questions, right? So a lot of what we're trained to do is ask these open-ended questions and dig and dig and dig. Well, in this field in particular, sometimes that may not actually be the best thing to do. I say this a lot with if you're doing like counseling for safety, right? And so instead of asking, is there a firearm in the home, particularly, let's say it's a well-traveled check and the mom is bringing in a child there and they have a partner or someone else in the house, and you said, oh, there's a gun in the house. They may not tell you, right? If, number one, they're not sure that there is a firearm in the house, or they don't trust you and what you may do with that information. So you may put them in a really awkward position in answering that question, or they may, it may, again, kind of harm that trust relationship you're trying to build. So sometimes you can just make the statements and saying, for some people, they are concerned about, it can be hard to workshop the way that you would say it. So one way you can say is a lot of patients may feel unsafe because of things in the home that they don't always have control over. And what are ways in which that safety can be improved, right? And so as an example, one of the things is a lot of patients, a lot of parents tell me they're afraid of being hurt. They're afraid of their kids being injured by something. One of those things is weapons or is guns. And maybe it's from a friend of theirs. Maybe it's from somebody else in the home. What I just tell all families is that the safest way to have a gun in the home, if it's something that somebody there owns, is that the gun and the ammunition are kept separately. And that there's just no way for a kid to be able to get at it. It's not just like up on top of the fridge, right? Or in like a cookie jar somewhere. Kids know how to get at things. They know how to get at the cookies. Just make sure, if that happens to be the case for you, that things are stored safely and securely away from all access to children, right? Same thing with poison, same things with cleaners and stuff like that. And you kind of transition. And again, making that statement sometimes just puts it out there and lets people warm up to it, without then kind of making a judgment by asking the question, which is what some people feel is invasive. Point 4, be specific with questions and know what you're going to do with answers before you ask the question. So what are you most concerned about? Is it possible to make sure that there's no way a child or teenager can access firearms or ammunition? Are you worried about your safety? How do you feel about talking with the police if you are scared about something? So help people to try and safety plan a little bit. But before you ask those questions, think, what would I do with the different answers that they give? And it's okay to work up some experience and some time in building up the courage to doing these things more regularly. And after you ask these over different experiences and different clinical visits in time, you'll build more confidence and a bit more savvy with how you phrase things and how you ask them in different conversation contexts. Point 5, again, avoid incriminating questions, right? Don't put them in a tough spot. Don't ask if someone's in a gang. They're not going to tell you that. It's just kind of, in my mind, it's kind of a pointless question, right? Because what are you going to do with that information, right? What are they going to do with telling you that information? It just doesn't help. Well, the question is more directed as, are there people in your life that are involved where you don't feel safe, right? Or do you feel like you may be getting into a fight or dragged into something like that because of something that your friend's involved with? Even that can get a little bit careful or a little bit tricky with the phrasing. Again, you can workshop that, think it through, try different ways of saying it. There's some great videos online in talking about it and some of the resources I'll show you later. And again, be careful asking about any kind of disclosures and have a plan on how to handle them. Hopefully Esperanza or others have some kind of protocol for what things are mandatory disclosures versus not. You need to know the laws of your state as well in doing it. This is probably the best and most clinically relevant point here, point 6, and this is my last one, is ask about mental and behavioral health needs, right? And so for all the stuff that we're talking about, violence and firearms and trauma and things like that, at the end of the day, what is the person in front of you probably struggling with the most, and what are you most likely to actually be able to make some kind of impact with? It's with these things, right? And so being able to sensitively bring them up when they're ready for it. So here are some phrasings. Sleep is actually a really big issue, right? And often is the most recognizable symptom for particularly young men whom, if you asked about their health in every other dimension, they're more likely to tell you, I'm fine, no problems, don't worry about it, I'm okay, I'm fine. Say, how's your sleeping? Oh yeah, I've been very good. Have you been having nightmares, right? And then oftentimes they've never been asked that question before, right? And then it becomes a way to kind of bring up PTSD and then be able to say, hey, maybe this is a sign that something that isn't really sitting well with you. And, can you tell me a little bit more about what it was that happened? Like, what is it that you're having nightmares? Do you feel worried that might get hurt again, so like that, and so again, sleep is a big thing. Try to avoid asking about triggering events unless you are prepared to dive into it more and they are prepared to dive into it more. And that's about as much as I can say about it. I'm not a mental health clinician. I'm not an expert in these things. This is just some of the things, like clinically, when I'm seeing them in the hospital, that come up and I found is actually a very easy segue and transition point into being able to dive into it. Right? So that's pretty much most of what I got for clinicians. This is a fantastic resource, the Bullet Points Project from UC Davis. It's really developed a lot. There's always something new on there. And so they have videos, they have guides for different clinical scenarios of how you would say things and workshop them out. So I really, really recommend that. And then for further reading, a whole bunch of slides about Philadelphia more specifically. But here are a number of great references, in particular this one. This person is a Christian and had herself survived being shot. And she goes into policy, into faith, into the intersection between those. And it's just a really good basis for talking about it. The title is When Thoughts and Prayers Aren't Enough. Really good book. Highly recommend.